Nilikuwa nikifanya kibarua kwa kampuni. Wakati epileptic iliingia, ilibidi niache kazi, nimhudumie sasa nimwangalie.
Whenever you tell someone, I live with epilepsy, there is certain discrimination. So many people still believe that it is nikurogwa. Something else, since I started having these seizures, sitembeleangi watu because you have to take your medication. The moment you take medication, hiyo dawa ni ya nini? Then you have to explain. Discrimination comes in, even from relatives.
These children, like the one now that is born with the cerebral palsy, the develop seizure disorders, they are not even taken for follow-up or for even diagnosis, a definite diagnosis and treatment. So they end up living a very isolated life. The condition of life for this young one, it is also affected because yes, there is treatment, but the parents are not strong enough. They don't have that support from the community to even take that first step.
The Epilepsy Pathway Innovation in Africa is a project being implemented in 4 sites across 3 countries. We have a site in Nairobi where APHRC implements the project, and we have another site in Kilifi where Kemri Wellcome Trust research program implements a project. 2 sites in Kenya, one majorly rural, and our site in Nairobi being majorly urban. We have other sites in Ghana and another site in Mahenge in Tanzania. In Nairobi, it was important for us to isolate the drivers and the triggers of convulsive epilepsy within the urban population. After identifying the triggers, then is to determine the burden. But we also aimed to evaluate an intervention within these populations.
EPINA project was one of our biggest things that we've done in Nairobi County when it started off. As much as it's focusing on epilepsy, we had very few epilepsy clinics, and again, it was seen epilepsy was being managed in silo. So what we did with the project is that they were kind enough, as much as MHGAP training was in the last quarter or the last mile of the project, we were able to bring it forward and train the clinicians on how to manage epilepsy. So that means that a patient with epilepsy doesn't have to traverse the county and go to a clinic. So the outpatient clinician is able to identify, is able to do diagnosis, and able to manage. So with the EPINA project, we not only saw an increase in knowledge, skills, and competencies in management of epilepsy, but across all the 7 priority mental health conditions, that is depression, psychosis, suicide, dementia, child and adolescent, epilepsy, and also other what we call substance use and other significance.
When it comes to EPINA, they started down from the community where they were able to do household screening for anyone that they can suspect. And then from there we came to facility screening. We had the clinician who are trained to do that, and then we had the neurologist coming on board to do the final diagnosis. For us, that is something that we've not experienced before. Bringing all those personnel, all those expertise down to level 2, 3 facilities, it is something that we really appreciate. It has not happened before, but with the EPINA, that is one thing we experienced, and it helped us to have a baseline data that we are still working on even now. Those are the same patients we are working with, and we are still recruiting more with the expertise that we get, because it was also a learning, moment for us, for myself. I would say that I was able to interact with the neurologist, and I was able to understand more.
Work with the Nairobi City County was a slam dunk move for us. We always talk about policy recommendations and uptake, but beginning and designing the training for primary healthcare workers with the Nairobi City County, I think, was really an important move. What we believe, therefore, is that the 100 primary healthcare workers that are trained, we really expect that the knowledge and skills gained will diffuse through the health system. And we already know that's happening, because for suspected cases at the primary healthcare, you actually have a lot of their colleagues also taking up the practice and learning about MHGAP IG, Mental Health Gap Action Program Intervention Guidelines. So that's happening, and we think that that will become a self-running machine. We really don't have to be there, we don't have to be funding the system, and we don't have to be involved in everything.
With EPINA project, it saw us for the first time, and I can proudly say that we are the first county to implement MHGAP in large scale. We also developed a dashboard. So we don't just did train, but we're able to get data. Even now I can able to show what are the cases that are being managed. So those are the greater part of the impact of the EPInA.
Beyond that bit about MHGAP, for the EPInA itself, the fact that there's a lot of conversation around the community on epilepsy. One thing that we know is that mental health literacy, and including epilepsy literacy, has been low within the population. And increasing mental health literacy and epilepsy literacy within the population, what it does is that it creates demand for care seeking. And what also it means is that a lot more people who suspect to have epilepsy will go to primary healthcare workers and be screened and perhaps initiated on treatment.
The reporting app that was developed by APHRC, that is one of the tools that they have to have online, whereby they are able to report any case that they have seen, the interventions they have given. They are able to classify where does this patient lie, and then even refer through the app, and even make a call to the right mental health professional.
Epilepsy being the issue here, EPInA really wanted to identify or document the drivers for the condition, but number two, really evaluate an intervention that can enhance treatment adherence among people living with epilepsy. The intervention was about an SMS-based trial that would then enhance treatment adherence by reminding people living with epilepsy that A, they need to seek treatment or go back for care or take their medication.
SMS za EPInA zimetusaidia sana. Ilikuwa ikitukumbusha vile tutapatia watoto madawa, na ilikuwa ikitusaidia sana, ungeweza kusahau. Na hapo awali tulikuwa tukisahau, hata utakumbuka maybe kesho asubuhi ndio nampatia mtoto na ni dawa ile angepata usiku. Sasa ilikuwa ikitusaidia sana.
They are reminding you to take your medication and also reminding you the day of the clinic. Yeah, it was very helpful. Okay. Because most of the time, you know, in Kenya we are hustling. Umerudi kwa nyumba, you are tired. The only thing you are thinking is bathing, eating and sleeping. So without that SMS, sometimes you forget to take your medication, especially at night. In the morning, it's very easy because you take breakfast with your medication. But at night, sometimes it's very hard because you are tired, you want to sleep, you have a headache, because there's that nature of a constant headache every single day. So you just want to go to sleep. So the SMS part of it was very nice. Ilikuwa inakusaidia kukumbuka.
You know, when you sit together with a mother, you have a child with epilepsy, the other one. So that aspect of support group. And then like now we are registering in one of the clinics, so that coming together, we have a challenge of access to medication. As much as EPInA did not come to sort, but now we have numbers to start a community pharmacy so that we are able to deal with those challenges.